All right, Dr. Rice, I think we're ready. Do you want me to stop displaying the agenda?
Sure.
All right.
All right. Good morning, everybody. Thanks for joining. So today's work group is for the airway related STRs for EMTs. And so that's what we wanted to discuss today. I think I have sort of two questions for the group. And maybe I don't think we're going to get through all of it today, but I'll pull up the one I do have started. Let me get to my PowerPoint. See, so let me share. There it is. Okay.
All right, it's firing up.
It's doing something. Okay. Can you guys see that CPAP presentation?
Yeah, we can see it.
Yeah.
Okay. So for this one, I didn't put a bunch up front. This is a placeholder slide. So one of the initial questions I had was whether or not we want to include any significant review material as part of this, or do you feel like it would be better to keep it very basic to just how to perform the procedure? I'm okay with either. But that was one of the questions that I had that we can maybe circle back to and see if we feel like we need this information.
I'm sorry, Amber, I was on the phone. Can you just repeat what your question was?
Whether or not we want to include a bunch of background anatomy, physiology, respiratory physiology as part of this, or if we want to just keep it very basic and to the procedure. I'm okay with either.
Maybe like I do think it's beneficial to have a brief moment of reintroduction to the anatomy. Maybe the difference between upper and lower airways, that dividing line there, just some really superficial stuff. I always find it useful, but it also could make it lengthy, I guess.
Okay. Yeah. But this is not a terribly lengthy PowerPoint, 20 slides. I think we have room for sure.
Okay.
If we're doing these as separate PowerPoints. So that will be one that maybe we can assign out to one person in the group to complete the anatomy section. And then I'll kind of go slide by slide. I did include just a little bit of physiology in here having to do with ventilation as it relates to both PEEP and CPAP. So I have in here, let's see here, and then inspiration, expiration. So this is just the physiology part. And then talk through how the pressure changes work in the lung, mechanics of breathing, and down in the notes I have just a couple of things that would be discussion points for in the notes for the instructor. This may
Let
be
me just catch up real quick. This is for EMTs and their application of CPAP in the pre-hospital. Okay, perfect. Sorry. Thanks.
Yeah. Sorry, I should have had a better introduction.
No.
And then we have basically what's necessary for ventilation. Sorry, I haven't edited these fully. I don't know if we want to specify that we're talking about the fusion of like oxygen and carbon dioxide.
I think that's probably
Diffusion of gases.
Yeah.
Maybe that's just a general term.
I agree, like diffusion of gases off across the alveolar capillary membrane, and then put something like actually show the alveolar, show the membrane itself. You know what I'm saying?
I have it here. It's just
Yeah,
small.
there's a little photo.
Make it bigger.
Yeah.
And then before I launched into CPAP, I just put in a slide here that basically shows what PEEP is. So that we introduced the concept of PEEP and what pressure at end expiration does to the alveoli. So essentially keeping some pressure in the alveoli at the end of expiration so that you can sort of explain this concept.
It's an excellent graphic, I think.
Oh, these are my Microsoft Paint skills.
Very good.
Strong work, strong work.
And then use that to sort of talk about what CPAP is. So CPAP being a way of delivering PEEP, but maintaining that pressure throughout the whole cycle versus just at end expiration. And then how the application of CPAP improves oxygenation. So let me know if anything I reach is confusing or needs to be deleted or clarified. And then
Can you go back to the last slide? I think I'd like to see alveolar recruitment as a phrase somewhere in there. That's that phraseology frequently occurs in examination processes for CEs and initials and things like that. So that would be kind of a reminder of that phraseology that they're kind of they're targeting, so to speak.
okay.
Yeah.
So I'll put it next to
Yeah.
decreasing atelectasis.
Perfect.
Okay. Thank you for that.
That looks good.
So indications and then contraindications generally follow.
I think the one of the major contraindications that is also taught in schools is altered level of consciousness. Any altered level of consciousness, which is kind of a direct. Oh, you probably do have in there. Inability.
I have
Airway. Yeah. Okay. Gotcha. My apologies.
Yeah. I have it in relative contraindications. I don't know if that's clear for people, but I mean, you don't have to have a GCS of 15 necessarily to have
Right.
CPAP.
Yeah, you're absolutely right.
You just have to have the ability to protect your airway. So sit up, you know.
Yeah, it's a good division of it.
This is the part I needed your guys' input on, since you guys work with different agencies. In our area, we only use these guys.
Mm-hmm.
Does
Yeah.
anyone
most
use
of
the machines? Is anyone using these other
those little
control units?
ATVs, little automatic transport ventilators. I've
Well,
never
they're not transport ventilators. They're just CPAP
oh,
controllers.
right.
We used to use the yellow ones, but not anymore. We have a vent. I think it'd be pretty difficult to give specific instruction, not knowing what equipment each individual agency might use. So
Okay.
sticking to like general principles seems like probably the safest bet.
So should we just get rid of this? These all three slides that have essential components?
Yeah,
I would.
You could talk about like that next slide looks at like the mask seal.
Yeah.
So it'd be important to mention, like, you want to ensure that you have a good mask fit and the straps are comfortable around their head, but like how you would titrate up your PEEP, for example, like would be maybe specific to the individual machine being used, and difficult for us to speak to.
Okay, so that solves that problem, because I didn't know exactly what people were carrying these days. We don't have anyone carrying in our area vents or the different controllers that I'm aware of. And I have 2 slides for procedure. And if you guys have more experience to how things that have been successful for you, this would be helpful too.
I think that top point's really important, is explaining to the patient what's going to happen because they sort of have to agree with the procedure in its execution.
Yeah, I would agree. And then also the having the patient hold the mask when possible, you tend to get a much faster, better fit if they hold it themselves versus you trying to manipulate that face.
Yeah.
And then maybe when you say secure with straps, something to the effect of like secure both sides at the same time or both sides evenly. Otherwise, you're like securing the right side, it pulls the whole mask to the right, and then you're trying to fight it back to the left, if that makes sense.
Yeah, absolutely.
I would put something in there about coaching the patient about the procedure. I know it says explain it to the patient and then have the patient hold the mask, but BiPAP or CPAP is more effective if you can find a way to coach them through the process.
Yeah. I have that on the second slide here.
Yeah.
Yeah. Do you guys usually start at 5 or 10?
5 is pretty
I
typical.
think start out at 5 and then you dial it up pretty quickly.
Should I say increase as tolerated?
Maybe increases.
I would say increase based on patient condition and oxygenization. Because as tolerated, they may be able to tolerate a PEEP of 20, except we don't need to go that high based on condition, because otherwise they're going to become like oxygen toxic.
Yeah.
EMTs are allowed to monitor end title, so it would maybe be worth making sure that we discuss that in there.
Can we do
waveforms or something?
I don't know that you can do waveform capnography during CPAP.
So you would have to do a side stream if it would fit underneath the mask and would not create a leak of seal, but that would be the only way. You'd have to use side stream without leak.
Do you guys use inline?
You could do inline.
Yeah, I guess it depends on what setup you're using, whether or not it will fit in there. But
right.
Most of the ones that I
absolutely.
It could be useful for like the education of why we're applying CPAP, because you would get some type of waveform patterns that might suggest that you need to utilize CPAP. So maybe we can use it in that type of capacity as well.
Yeah, I just don't know.
Like shark fin.
Go ahead. I'm sorry.
I was going to say, do something like shark fin waveform, patient's hypercapnic, something like that.
I mean, generally, I think of CPAP as being for primarily ARDS, also COPD to some extent, but mostly ARDS and oxygenation problems, not as much ventilation problems. And we do have an Untitled CO2 training as well.
Yeah, maybe it's getting more into the weeds than necessary by bringing that up. In this
Right, EMTs can apply end title, but they can't interpret it, right?
They can.
Oh,
it's an STR.
Okay, gotcha.
Yep.
Yeah, I do agree with you though, Matt. I think we might be muddying the waters a little bit there. It's a good idea though.
I don't have anything in this PowerPoint about COVID. FYI.
As far as like aerosolization and
Mm-hmm.
things like that.
Yes, I don't. But if we find a spot for it and you guys feel like we should put it in, we can definitely add it. It could be useful. I don't need that guy.
Maybe instead of patient begins to vomit, just say like airway compromise.
Okay. And then this part.
Maybe, sorry, again, I know,
Mhm.
I don't know, do you think we need to list the different
No.
I mean, you're saying supraglottic airway device, that pretty much covers everything.
I think so.
Yeah.
Hopefully no one's using a combi tube anymore.
Oh my goodness.
Please,
Isn't that
God.
funny? I know. I haven't seen one in many years.
They still exist prevalently in testing and on registry and that type of thing. It's interesting.
Yeah.
I might be a bit out of order here, but out of order of the slides, that is. But is there anything mentioned about the supply of oxygen that they need for good CPAP? Like they need to make sure their tanks are full at a minimum if they're going to be transporting any CPAP. Okay, gotcha. Sorry, thank you.
Oh, that's good.
You're on it, Dr. Rice. Thank you.
Anything else on removal?
Not even, no, it looks pretty comprehensive, honestly.
Mm. And then my intention was to list the different conditions for which CPAP could be used. I forgot to put my COPD slide in there.
Do we want to put those in the beginning part, like before the procedure, or?
Maybe like after the physiology.
Mhm.
Yeah, after the physiology and then before like an indications section, and then you go through each diagnosis.
Yeah, that sounds right.
So indications, contraindications, and then those 3 slides. And then talk about in each case what it would do. Are you guys using it for anything other than these things? I have CHF, COPD, asthma is questionable, but people do use it for asthma.
You could lump asthma, COPD together in the same, because
Yeah,
normally they fall under the same patient care guideline anyway.
It's true. I would say the indication for COPD is much, much stronger than for asthma, though.
Oh, I agree. But if you want to lump them into one to one slide deck. I guess it doesn't matter. You can separate them out. Just a thought, because they usually fall under one patient care.
Okay. And then there's obviously other reasons that we use it, right? Like COVID, pneumonia, as a sort of temporizing measure.
I do appreciate the way you described it a few minutes ago in terms of when you decide, when you determine that there's a need of it's an oxygenation problem, not a ventilation problem. That's a very nice kind of a general way to describe it in front of a bunch of specific things, I think.
Yeah. Mhm. I can't see the chat if you guys have something. It won't let me do both.
Oh, we just had a person join the meeting, and I requested at their name for the attendance.
Perfect.
I am going to have to hop off very shortly, but I don't mind writing the A&P section for this if you would like.
Do you want to do the anatomy part?
Yeah. Oh, I see it.
Or make any edits to the whole anatomy physiology section?
Yeah, I don't mind doing that at all.
Yeah, whatever you feel is necessary for that one.
Can you send that out to me, and then I can, thank you so much. I appreciate it.
Yeah, I'll send it to the whole group when we get done editing this one today. And then we'll kind of talk a little bit about the SGA one after this. I don't have pre-prepared slides for that, so I thought that one we could kind of assign out and folks could maybe work on that one. Then I don't mind finishing up these couple of slides about indications and specifics. And then we have I think that was kind of the end of what I had here. There's mostly information, not a lot of pictures. Obviously, I don't know if folks want more imagery. We could work on that.
I feel like the images would be tend to probably be specific to whatever machine you're using. And since we're trying to keep it, that might be hard.
Yeah.
Like the A&P ones at the beginning, I thought were great. I don't know what to do for like farther down the line though.
Yeah, I agree. There wasn't anything specific. I don't think we talk a lot in here. I don't have a lot of information in here about removing it if they're hypotensive. I have in here in contraindications, I have sort of like relative contraindications, but I don't have anything else in here that talks about some of these things more in depth.
I guess the ventricular dysrhythmia. So this is just for EMTs. Can they interpret an ECG rhythm? They could apply the 4 lead, but they're not going to know that it's necessarily know that it's a ventricular dysrhythmia. So
do I have that somewhere?
Where you highlighted right there.
Oh.
Shock with the need for pressor support and ventricular dysrhythmia. I'm wondering.
Yeah.
You might
just say shock.
Hypotension or shock.
Yeah.
I mean.
Yeah.
Yeah.
But do we need another slide about intrathoracic pressure and shock, or do you think that this is enough? I just wonder if we need to expand on some of the contraindications a little more.
Right.
or if this is enough.
If we're specially training them for this skill, I suppose they ought to have all the information available. And one of the risks of a CPAP administration is that increase in intrathoracic pressure and what that does to the great vasculature. So I mean, I suppose it would be worth adding another slide. I'm more than willing to do that. That we can kind of stick in and kind of go into a little bit more of these the why as to some of these contraindications, just so they have some good foundation, I suppose. I don't know.
I don't know.
Sure. And then are we like, is it, we're just kind of saying, monitor blood pressure. Well, what kind of events lead to that intrathoracic pressure? Is there sort of any telltales before they get there that can kind of set them up to think?
Just the CPAP in general will increase your intrathoracic pressure. So if you put someone who's hypovolemic or already kind of hypotensive on CPAP, you run the risk of lowering their blood pressure further.
Something simple, perhaps like overinflation of the lungs can cause collapse or compression of the great vessels and further lower blood pressure.
You can also add if increasing the rate of centimeters of water will increase intrathoracic pressure. Like, so if you take it from 5 to 10, from 10 to 20, from so on, that'll do it too.
That looks excellent.
Is it worth, maybe this isn't the right slide, but just commenting on the risk of CPAP causing a pneumothorax if you've titrated it up too high, the lungs are frail, that sort of thing?
Yeah, I wonder if I have a slide in here that's like complications.
Like no greater than 20.
Yeah.
Oh, you have it right there in the middle.
I do. I haven't broken that. I'm sure I probably just copied and pasted this from somewhere, but I don't know about the abdominal compartment syndrome part. I don't think they're going to understand that. And then what did you want to put in here about pneumothorax? Should I make another slide?
I don't know. I guess I just wanted to like make sure that people are aware that that's like a pretty serious complication if it happens, and to be paying attention. You do have it listed in that.
Do we have potential complications?
What's that?
I thought we had a section of potential complications.
Yeah. So what would you say? What would you put in here for recognition?
Hmm.
To be specific, we're talking about a tension pneumothorax, right?
No, just a pneumothorax.
Okay.
You could say, a sudden worsening of respiratory difficulty,
Mhm.
or sudden increased work of breathing.
Mm-hmm.
Like question mark whether or not you'd hear any change in lung sounds. Really,
Yeah.
nothing. Yeah.
Respiratory. What'd you say again? Say it again. Sudden worsening of
Respiratory effort. Yeah, that's sudden worsening of
respiratory distress.
Yeah, maybe it's sudden increase.
So, yeah, that's kind of what I was about to say.
Respiratory
Sudden
distress.
increase of respiratory distress.
I don't know if you'd see like an initial drop in SATs. I kind of don't think so.
Probably not. It would take a while.
Right.
Or it could.
A change in lung sounds. I mean, that's why I was saying asking tension, because then we're talking about the lack of lung sounds from the affected side.
I just don't know if like listening to lung sounds is all that accurate or specific.
Yeah.
I think that's good.
I like that a lot.
Yeah, people might be apt to be like, well, 5 didn't work, 20 is the next step. It's like, well, maybe we should take baby steps and not jump to this enormous pressure.
Yeah. If void pressure is greater than 20.
Well, that's probably going to be a per protocol, huh?
It will.
So I think your line above that, the limit CPAP pressure to the lowest effective level, is a pretty good spot to be.
Okay. Especially.
Yeah, I like that.
Do we want to move the complications slide up at all? I don't care.
What's the order that it's in right now? Sorry.
Right now, it's like we go through the procedure, how to do it, patient improvement indicated by improvement in blah, 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 and then when to remove it. And then we say special considerations, and then we go to complications.
That seems like a good order.
Okay.
Yeah, I think that's okay.
Okay. Okay. So we have anatomy.
Oh, sorry. Will you go back to that last slide again?
Yep.
Since we're not really describing the equipment, maybe just say describe the preparation and technique in regards to the application of CPAP.
Perfect.
Sorry, I know it's nitpicky.
Nope, not at all. We took it out.
Yeah, I think that looks good otherwise.
Okay. So we have anatomy, some physiology slides, which she's going to look at. What is PEEP? What is CPAP? indications. I have respiratory distress, but not hypoxia on here. Would you guys add hypoxia?
Yeah, I think that's reasonable. You know, we like some of our indications are typically like obviously like increased work of breathing, hypoxia, increased respiratory rate, you know, some of those things.
Yeah, I'm going to put in here, I'm going to kind of do it like this. I might break this up into 2 slides then. And do one slide that has hypoxia, increased work of breathing. What were the other ones you mentioned, Matt? Increased respiratory rate?
Yeah, I think those are the hypoxia, increased work of breathing, respiratory rate.
Maybe I don't need 2 slides. I didn't add that much.
I'm just going to our QI form real fast because I'm having a hard time remembering at the
I
moment.
know. You have a QI form for CPAP?
We have a QI form for any ventilator use.
Oh, interesting.
Yeah.
BVM?
No, not really.
Okay.
Any like mechanical ventilator
Yeah,
use.
yeah, yeah.
Sorry.
That makes sense. Are you still looking, Matt?
Yeah, sorry, I'm also on shift, so I'm multitasking.
Oh, okay.
So our QI form, sorry, it's a respiratory rate, skin color changes, so modeling, cyanosis, pallor, increased work of breathing, presence of abnormal breath sounds or frothy sputum, and hypoxia, pretty much.
Say that last one before hypoxia.
Presence of abnormal breath sounds or frothy sputum.
I like that.
Thanks.
Okay, is this 2 slides or 1 slide? What do you guys think? I feel like it's a lot for 1 slide.
I think they're kind of
But
sort of 2 sets of information. Yeah, I think it might be a lot for 1 slide.
I am going to. This one's more like recognizing respiratory distress.
Sorry about that. Nothing's going to plan today.
Nothing?
Nothing.
Oh, no. Okay. I think it looks pretty good. So I have our indications here. Maybe these are what go on our slides. So that we just expand on all those.
Yeah, I think that's a good idea. Stick to the same terminology.
Yeah. And then what was the other one? What was the other one I had on there? Okay.
On that last slide, does that say contraindications, those with advanced, with the DNR? Is that what that last slide that you just had up there said?
No, it was other indications.
Oh, okay, gotcha. Patients.
Yeah.
Okay, so indication, that's okay.
Yeah.
Yeah. Okay, cool. I was just making sure. Thanks.
Yeah. Okay. So basically we need to expand these 3 slides, which I can definitely add in. And then someone was working on the anatomy. And then the next one, like we're definitely not going to have time to get through the whole supraglottic one, but I thought maybe we could break up the PowerPoint. So I remember what it is. Into our sections, and then we can assign the sections, and then we can work on the SGA one maybe together offline.
Sure, that's
Yeah.
fine. How do you
Is
want
there
to split that?
already a supraglottic training or no?
I don't know. There's not.
Okay.
I'll double check, but when I looked
Again,
today,
it's gonna be somewhat specific to what supraglottic you're using, right? Like placing a combi tube is going to be very different than placing an eye gel.
right. And so that's where I don't know if this is its own presentation or if this is an add-on to this one as part of the STR. Because if you're doing it as an STR, it has to be comprehensive enough, I would think. Right?
Yeah, you would think so. I have, for what it's worth, I have like 2 full PowerPoints on eye gel placement and king placement.
Oh, really?
Yeah, because like at one point we used kings here, and then now we use eye gels. So, but each of those are like bulky, right? Because they're
Right.
like the whole presentation.
Right.
I don't know if we want to do that for every 2nd generation supraglottic airway that's out there.
Would this then turn into more like a general overview of some of the principles of them rather than, and kind of like last time, avoid the specifics of them because they're manufacturer specific?
I mean, I think that's the hard part is the indications are very limited, right?
Mm-hmm.
I mean,
Right.
it's basically cardiac arrest for EMTs. There's no other reason. You can't have a gag reflex. You basically have to be dead. So their indications are pretty small. And there's certainly contraindications and troubleshooting tips, but again, very device specific.
Yeah.
But I mean, if you're
Yeah, it's hard
doing
to talk about.
Yeah. If you're thinking of doing an STR training, it has to be like every device specifically has to have its own STR training. So we could create one for iGels and one for Kings and just leave it at that, since those are the two most common.
Yeah, I was going to ask, do we have any idea what the most common supraglottics are?
In Southern Arizona, I've only seen the iGels. I've not seen a King in Southern Arizona in a long, long time.
Yeah.
And I haven't seen LMAs or any other type of device either. I've only seen iGels in the last several years.
Mm-hmm.
I don't know about you guys.
iGels.
Yeah, it's been iGel for us in our kind of bordering agencies, but I'm not sure about the more rural ones who might have invested in Kings and then, not been changed to something different.
Yeah.
Hey, Amber, it's Heather from Kingman, and out in the Western region, we all use iGels, and so does DPS. AZ DPS helicopter uses iGels out here too.
So maybe we just do an iGel one?
Simple, right? And then does it look like the state is recommending a specific supraglottic? Is that an issue at all, or not really? We normally steer clear of specific brand names,
You're right.
We do, but what are the other options though? Are there any other options besides iGels?
Any other supraglottic options?
Well, I mean, like besides the Kings, like if literally no one's using it,
Right.
then it seems silly to invest the time in making a training for it.
True.
If people wanted it, we could always make one, but
It seems like it's hard to talk about specifics of iGels without talking easily sliding into manufacturer specific stuff. It's which is a little counterintuitive, but yeah, if it's a STR, it has to be comprehensive in its education. It's like, well, since even placement is manufacturer specific, it's very difficult to kind of produce that.
yeah. Shelley, what are your thoughts about, is this something we need to take back to the education committee or?
Sounds like iGel's the winner in the state, and we can maybe put an asterisk, other Airway mess, blah, blah, blah.
Mm-hmm.
Yeah.
Yeah, maybe the state's recommendation is simply that it's a second generation supraglottic, not, at the very least, doesn't have to be an iGel, but it shouldn't be like a first generation element.
Right.
Right.
It's a good place to start.
Yeah.
Yeah. Yeah. We could start, would you mind offering up your presentation, Matt, for starting point for this one?
Oh yeah, totally. I mean, I totally can.
Okay. Because that may be maybe a little bit more efficient.
Yeah, and I mean, a lot of it too is from whoever manufactures the iGel. A lot of it's from their website,
I think that's how ours is too.
Yeah. I'm not
think
reinventing the wheel up here.
Yeah, a lot of it's just providing a resource for. I do think that it's a commonly used STR, so
yeah.
I do think for that reason, I think it would be nice to provide folks with something. Where is here it is. To provide people with at least something, just because it is a very common STR.
Yeah, that's fair. So do you want me to, I can go through it and just make sure that I remove anything specific to Guardian, and then I can send it to Shelley.
Okay.
Yeah.
What do you think, Shelley? Would that work? And then I'll make the edits on this one and send it out. And then we can kind of review them offline as well.
That sounds good.
For like final changes. And then if we need to come back together for this one or the death notification one, we can maybe do
time.
One more if we had to.
Okay.
Because these should both be mostly done. And I think some of it will just be folks kind of looking through one more time and making sure there's nothing silly or that they don't want to add anything, and then we can send it.
Yeah, I'll have to find the citation for that other PowerPoint.
What's that?
I'll have to look for the site that I got a lot of it from, because it's been a while.
Yeah. It's probably intersurgical.
That's probably true.
Yeah, would be my guess. Surgical.
I made it a while ago, so.
Yeah. It's old. Okay. What else? Anything else for this one? I don't have much else for this one. I'll go ahead and put those edits in right now and send all those out to you guys.
So good.
Yeah,
I'll try to email you in the next couple days with the iGel one.
Okay, sounds good. All right. Does anyone have anything else? Any other suggestions? Otherwise, I'll give you guys a half hour back and work on the rest of this stuff we can send out.
I don't. Thank you guys.
Awesome. Thank you guys for joining and giving your input. It's super duper helpful.
Yeah.
Incredibly helpful. All right. Anything from you, Shelley?
Great. No, it's a great start to
Okay.
getting all the STRs done.
All right. Thank you, Shelley.
Thanks, Dr. Rice. Thank
Yep.
you, everybody, for today.
Yeah.
Yep.
All right.
See you guys soon.
Thanks, everyone.
Bye, guys.
Okay, bye.
Thank you guys. Bye.